Hello, my name is John Marshall. I work at Georgetown University. I'm the chief of the division there of hematology oncology, and glad you're joining me again for another installment of my video web blog on Medscape, really focusing on colorectal cancer, GI cancers, and a little bit about the world and how things are going. Quickly today, I really wanted to focus on a drug, Bevacizumab or Avastin. It's been in the news a lot lately. There is some new evidence around toxicities that I wanted to review briefly, but I also wanted to look at the drug and its impact on the management of colorectal cancer and some of the studies that have been done more recently. Let's focus first on that toxicity issue. Last week, actually 2 weeks ago now, published in JAMA was a really nicely done meta-analysis looking at a big collection of trials and focusing in on the issue of deep venous thrombosis or pulmonary embolism, venous clotting problems with patients being treated with Avastin. For a long time we've known that arterial clotting, strokes, heart attacks were increased, small amount, but increased in patients who were receiving Bevacizumab. But we'd said, you know, the studies hadn't shown an increase in DVTs. Well, once this big meta-analysis was done, 8,000 patients were analyzed, there was a clear observation of a relative risk of 1.33 for deep venous thrombosis. Many of us, even though we've said officially, you know, there wasn't this increase that was seen in the studies, sort of wondered if, in fact, how could it be that we had arterial clotting and not venous clotting? This basically clarifies that and says, yes, there is an increased risk. Not really sure what to do with this data, quite honestly. I don't think it's a call to put everybody on prophylactic anticoagulation. We've sort of already incorporated a lot of our practice management styles into this already. We've been using this drug a lot. Patients have lots of clots. We already sort of know how we're going to handle those. So I don't think it really changes much, although it does add to the list of things that we need to talk with patients about. So that's the news on the toxicity front. But I wanted to look at Bevacizumab and Avastin from another angle. I was recently looking at high schools with my daughter, and we were in the science class and hearing the science teacher talk about an experiment that was really designed not to go so well, where the results were going to be different than what the students expected. And I thought immediately of a clinical trial called what we call 966, where it was a simple study, big study, FOLFOX or Zelox plus minus Avastin. And we all expected for that study to come out positively, where Avastin, Bevacizumab, would improve the progression-free survival and ultimately the overall survival when added to FOLFOX. And the surprise was that, in fact, that study was not positive, that the magnitude of the benefit of the addition of Avastin was not very high. And it was puzzling, and so we spent really the last year or so trying to understand why that experiment came out negative. And one of the things that emerged was that the docs who performed this study really stopped all the chemotherapy cold turkey. They didn't keep giving chemotherapy until progression. There are plenty of models where you don't do that. You give so many cycles of chemotherapy and stop. But in colon cancer, it appears, based on that study and some other data, that by giving this chemotherapy until patients progress, giving them something along the way, would in fact result in an improved outcome. And when they did a subset analysis in that clinical trial of those patients who kept getting their treatment, there was a much better benefit that was observed. So that was our take on why that trial was negative, but then it's caused me to think of really one other angle, and really the last point I want to make. When you look at the benefit that we've seen in colorectal cancer over the last several years, the addition of irinotecan, oxaliplatin, EGFR blockers, VEGF blockers, and the like, if you look at each of the clinical trials that was done that showed an improvement in outcome, the magnitude of the benefit in each of those clinical trials, 2, 3, maybe 4 months at most, if you add them all up, they don't add up to the benefit that we're now seeing in patients with colorectal cancer, meaning that if you add the 2 months from frontline therapy and the 3 months from second-line therapy, etc., it doesn't take us from the 5-FU only world where we had a 10-month median survival to now the 7-drug world that we're in where we have a 25 to 30-month median survival. So it doesn't add up, as I like to think about it. And so it suggests that the way we do clinical trials, the way we set them up, making these perfect experiments, if you will, don't really reflect what's happening out there in the world. We're doing better when we get to play with the drugs out there in the world than the clinical trials and the objective measures really give us credit for. And I realize that this is going to be important as we defend our practice, as we go through healthcare reform and have to justify what we're doing. We do have to make this point that what happens in the objective published PDR version of our clinical research is really not what we play out on a day-to-day basis in the community. And I think Avastin and all the study results that have come out with that recently are really a perfect example of this. So again, just some food for thought, and come back, we'll talk some more. Thanks.